Welcome to the winter edition of It's Your Health. Philip Benyo with Philip Benyo. We're here to inform you about what's new in the healthcare field. We'll be right back after this brief commercial message. Make sure you check with your healthcare provider before doing any of the things that we talk about here on It's Your Health. Remember, we're your leader in healthcare information. We'll be right back. Welcome back to the first segment of It's Your Health. We're here to show you how fast 30 minutes can go.
Well, here it goes. Let's get started off with some headlines. Eating less red meat may help your heart.
That seems kind of like saying the day is when the sun shines. I mean, it's pretty obvious, right? I think it's a question of balance in life, and red meat has gotten kind of a rap, although I still like steak and eggs. So
it turns out the redder the meat, the worse. What happens, at least theoretically, there's amino acid called carnitine that your gut converts over to trimethylamine, which turns out to be a free radical, and that ends up increasing inflammation at the blood vessels and hardens your arteries. So maybe more veal, less liver.
How about more fish oils and more bacon?
We'll get to that later.
Okay.
All righty. Next headline. Smokers in car pose risk to passengers. We're going to do obvious headlines today.
All right. No brain headlines.
When it's night, it's dark out.
Again, this seems to be a no-brainer. They're talking about passive inhalation of cigarette smoking. And there was a recent commercial I saw where they akin smoking to inhaling 7,000 bad things into your lungs. And of course, that is almost right behind where you're doing passive cigarette smoking as well. So I think the Star Trek generation is going to be smokeless, don't you think so?
I think so, yeah. It has to at some point. If we could do it all over again, we would just disinvent cigarettes. It's that simple.
There you go.
Moving on, another booming headline. Alzheimer's cases expect to double by 2050, with the cost over 5-fold increase.
Well, it's multifactorial. We're seeing more of that disease. We're diagnosing it more, and people are living longer. And so we're not equipped for this geriatric tsunami of Alzheimer's cases. And once you're diagnosed with it, you can continue to have behavioral problems for many years. You may not be able to stay at home. Caregiver burden is high, and so it's a problem that I don't know where the answer is, except perhaps to try to find and diagnose these patients earlier and start treatment. And unfortunately, the treatment is just with parachute drugs. It will slow down the disease. It's not going to stop it or reverse it. So
that's where the research is trying to figure out ways to stop and reverse it, because we haven't been able to do that yet. And slowing it down in the end makes it cost more, and people are living longer, they're living harder too. We're not helping each other. There's a lot of different risk factors out there. Moving on, let's talk just briefly about some new meds that you're starting to see, we're seeing commercials about, and there's a broad classification we call glucose transporters. There's 3 new ones to the market. We have Invokana, that was the first one to the market. We have another one called Farxiga, and the last one, Jardiance. Have you had any experience with these?
I think they're going to be revolutionary, and the way they work is, if I can back up a little bit, the function of the normal kidney is to filter blood and reabsorb sugar. And what these drugs do is the opposite. The blood, of course, goes through the kidney, but it dumps the sugar, which it ordinarily reabsorb. It dumps the sugar into the urine. So you basically pee out perhaps 2 candy bars of sugar every day. And that translates to good things, right?
Well, it'll help lower your blood sugar. That's certainly the effect we're looking for. It also has a neat effect of causing weight loss, a neat little bonus side effect. It's rarely we get bonus good side effects, but we have one here because we're taking literally calories, about 70 grams of sugar, and we're transporting it in peeing it away. You know,
Right.
you're peeing calories away, and so that's a unique advantage to these meds. You know, so not a lot of long-term data as far as to, you know, how this is going to work in the long term, but certainly it's one of the many things we now have in our armamentarium. And speaking of diabetes, you know, I get that question a lot. You know, when should I start screening for diabetes, and what are the things we need to look for? Who's at high risk, who's not at high risk? How should we be doing that?
We should be doing it more often because too often we end up diagnosing diabetes when it's obvious, and we need to get those patients in what we would call a pre-diabetic, kind of like the pre-hypertensive patient. I think if it runs in your family, if you have weight issues, if you have a fasting blood sugar that's kind of like on the borderline, I don't know what else you could add to that mix.
Well, if you look, we actually have a little thing we can look at, you know, and see that, you know, testing should be considered in any adult who is overweight, a BMI greater than 25, who has physical inactivity, has a first-degree relative with diabetes, real high risk with genetics, has a high-risk race or ethnicity. You know, we see it a lot more in American Indians, African Americans, Latinos. Women who've delivered a baby who was greater than 9 pounds or was diagnosed with gestational diabetes. It turns out most of these women, 10, 15 years later, they're going to be a diabetic. You know, and we're finding real big evidence of that. Anybody who's hypertensive or has high blood pressure or is being treated for high blood pressure, just because you're getting something for your high blood pressure still means you have it. You have an HDL less than 35 or triglycerides greater than 250, and women with polycystic ovarian syndrome, and anybody who's already had some issues with their sugar. You know, we should be screening those people every year. And for the general population after the age of 45, we should be at least checking it every 3 years.
Right. And would you recommend a hemoglobin A1C? Is that, or how do you screen for this?
Ideally, it's just a fasting blood sugar. But even random things are well equipped if you kind of know when someone ate. If someone had eaten with, you know, and it's been 2 hours after they've eaten, their blood sugar is over 140. That tells us there might be some issues here. Right. But if their fasting is, you know, certainly greater than 126, they're automatically a diabetic. But if they're in the in-between land, you know, that warrants further study.
And it goes without saying that's another disease that is going to be an epidemic or has already crossed epidemic proportions in our society is diabetes. So word to the wise.
I think it'll be interesting as healthcare providers, we have to look at other places to screen. You know, we always screen here in the office, but you know, how many people have never seen a doctor or gone to the ER in the last 10 years? We need to, instead of sending people out to health fairs, we should be having blood sugar screening at a football game, at a state fair, at things that you would never think to have your sugar checked. If people came up and they got a free something and get their sugar checked, you'd be surprised how many diabetics you'd find that never knew they had sugar problems.
We'll have to get a booth at the Bloomsburg Fair.
Yeah, that would be wild.
That would be a popular place. Speaking of popular places, you're at the best place for your healthcare information. It's It's Your Health. We'll be right back after this brief commercial message. Welcome back to the second segment of It's Your Health. I'm here with the Fipster, who is going to go through the major headlines of the day.
Yeah, we're going to try to make these less obvious.
Okay.
Fish consumption and acute coronary syndrome. A recent study suggested that there's an inverse relationship. The more fish you eat, especially healthy fish, the less coronary artery disease you have. We've talked about that before.
Absolutely, fish. And we hope fish oils are going to lower your vascular risk. Keep in mind that we're having a fight in our body between omega-6s, which are very inflammatory issues, and the omega-3s, which are sort of the brake, and they reverse and are potent anti-inflammatories, of which cardiovascular disease is one. So if you can't have the fish oil. Is that sort of it?
Correct. Moving forward, improper contact lens use can increase risk of eye infections. Surprisingly, there's a lot of people who put their contacts in and leave them in for a few days or don't clean them properly. I'm surprised at that because as a contact wearer, I wear dailies and they toss. I could never imagine falling asleep, but you can have an increased risk of keratitis with this.
Right. Well, they're foreign bodies, of course, and you end up scratching your eye or trying to rub your eye with who God knows where your hand was, what doorknob it opened. And so the risk of eye infections, foreign body, ulcers, bad things happen because, let's face it, you're putting a foreign body on a very thin tissue of membrane, which may not like it.
Yeah. All right, now let's talk about something I know that you do like to talk about. It's something we talk about a lot, and it's certainly in our geriatric population, this is a big problem, polypharmacy. How would you define what that means? Because we use the words a lot, and what does that really mean?
Right. Well, I generally look at patients who have more than 4 or 5 medications, and that's when the harbinger of polypharmacy, too many pills, shows its head. And I often tell patients, and I'll wave my prescription pad in front of them, that's the most dangerous thing I have, is a prescription pad. Once you get on 4 or 5 medications, they start interacting with each other, they start interacting with you. We end up cascading, and it's very common in our line of work to inherit a patient at a nursing home who you're treating a side effect with another drug. I mean, you just want to hit your head and say, what's going on here? And it just has to do with how complex medicine is. Every specialist is throwing in their ingredient to the soup pot, if you will, and you need a quarterback to help go through this. And what I tell patients is stick everything you have in a brown paper bag. It doesn't have to be a brown paper bag, but bring it into us and we're going to sort it out and say, perhaps you needed that, but you don't need it now.
Yeah, it often, with people not updating their med lists that they have, they often sometimes will get duplicative drugs, 2 of the same type of drugs put on and not know it. Or I think the advent of the electronic medical record system has helped because we can see what other providers are doing, but that's dependent on all the providers using the same EMR, which doesn't happen. But certainly it doesn't help. It always helps to look at the bottles.
Yeah,
okay.
No doubt. And you have patients who go to different pharmacies, they have mail-in services, and it's a real jump ball sometimes as to what goes on. And intertwined with that, which I think you're going to get into, is not only the polypharmacy of prescription medicines, but the medicines that you shouldn't be on to begin with. Period. End of statement.
Yeah, there are depending on the age population, there are such thing as bad drugs. The American Geriatric Society has studied it, and they published this list called the Beers List. And the Beers List you'll hear about from time to time is a list of medications that just should not be used in the elderly. And if they are used, they have to be for specific purposes and watched with great caution. And I'm sometimes shocked when I look at someone's med list. They may not just have 1, they may have 3 or 4 of these medications that they're taking.
Right. High incidence of side effects, urinary retention, falls risk, changes in mental status. We see it time and time again where we see a patient who has behavioral issues. We end up stripping 1/3 of their medicines away, and guess what? They kind of wake up and say, what happened?
Right.
It's just one of those crazy things.
I thought it'd be helpful actually to kind of like put these lists up because we can talk about it, you can Google it, but let's actually put them up on the screen. And so the first screen here we have are the anticholinergics. These are pretty evil drugs. We're talking about promethazine, hydroxyzine or Atarax, Benadryl, diphenhydramine.
Yeah, some of them are over the counter and are poisonous to our older people. And I'm surprised they don't have this, when you're picking it up and reading about it. Some of our elderly should not be on these things.
Right, and also on that list is we have certain anti-Parkinson's agents like benzotropine or cogentin. That has highly anticholinergic. Also belladonna, hycosamine, scopolamine. These are spooky drugs.
Yeah, I think some of the antidiarrheals fit into that category. What else do you have on our list?
Well, the next screen we have things like Ticlid or ticlopidine. These are antithrombotics or antiplatelet agents. On the next screen, we have our cardiovascular agents, different types of blood pressure medications, your alpha blockers, your Cardora, your Hitrin, clonidine, high-dose digoxin, nifedipine, high-dose aldactone. These can be scary drugs.
Right, and along with that, the older antidepressants, tricyclic antidepressants, clearly not indicated for the elderly. They're old con drugs, and I think what we run into a problem with are the benzodiazepines.
That's a big problem.
Big problem because they're used rather generously for anxiety and sleep disorders, but they put you at a higher fall risk and a chance for bad things to happen.
And the same thing with the hypnotics. People are taking Lunesta or Ambiens of the world. I'm surprised at how many 80-year-olds come to us who are on an Ambien prescription. And it's just. It's surprising.
Right, and what often happens in the elderly is they reverse their sleep cycle. They're up at night and they're sleeping during the day, and family members or somebody wants to reverse that. And
just think a pill's going to do that. Yeah. It doesn't work that way.
They need to get good sleep hygiene, and so Moving right along, some of the endocrine drugs.
Yeah, testosterone is something that we see used in middle-aged men, but certainly there's no place for it in someone who's over the age of 70. Estrogens that are not used with progesterone, really dangerous. Sliding scale insulin, I'm kind of guilty of that. Sometimes we do use that, but that's, treating a high sugar after it happens and not actually trying to prevent it. Megase, that's a big one that often you see used as an appetite stimulant, and sadly it doesn't really work, and it has a lot of side effects associated with it.
Another big category, of course, are the non-steroidal anti-inflammatory drugs. They really should be not used. They have not only ulcer-producing properties, but they may end up causing kidney failure, and are just to be avoided.
Yeah, they increase the dose of, or increase the risk of just cardiovascular disease, stroke, and heart attack.
Yeah.
Even the high-dose aspirin. I have a lot of people, I'm surprised how much aspirin they take just for pain. They take about 2 full-dose strength aspirins, and that's amazing. That's going to cause problems.
Exactly. And the Nuprin or Advils, not to pick on them, they also increase your blood pressure. So
Absolutely.
again, we have patients who are arthritic patients on Nuprin, Advil, and they come in with high blood pressure. Get rid of the Nuprin or Advil, your pressure may go down. So the list goes on and on. I think you just have to be very vigilant that the pill is not the answer. It may be the problem. But this is not the problem, because I told you it's the fastest 30 minutes in television history. We're going to be right back after our third and final segment of It's Your Health. Remember, you're watching the leader in healthcare information. We'll be right back. Welcome back to the third and final segment of It's Your Health. Phil, maybe you could just comment on our new name. We've been showing it here, Lehigh Valley Physician Group.
Yes, we're very happy to now be a part of the Lehigh Valley Physician Group. We're officially been assimilated, and it gives us great access to a number of different specialty groups that are easier for us to get access for our patients. It gives us better support. In fact, tonight we'll be going to a meeting with one of their specialists to talk about how we can provide better patient care.
Right.
Very exciting. I think it's only could mean good news for Hazleton.
There's no doubt, and we join a group of 1,000 practitioners within a very small radius, so it will increase access, and all boats will rise as the tide goes up. So, with that said,
artificial sweeteners can raise your blood sugar.
Geez, I don't like that. I don't like that because I use Splenda in my coffee, and here you're telling me it can raise my blood sugar. Tell me, why is this happening?
It turns out, and it's very opposite of what we think, but you know what? It turns out we've noticed with artificial sweeteners, people do gain weight. We've talked about that. What happens with artificial sweeteners such as Splenda, aspartame, and saccharin is that it disrupts the gut flora and fauna. The bacteria in your gut change the way they handle this, and it ends up causing the sugar to raise. And it doesn't get into a lot of specific, but they did experiments with mice and showed that they were able to get them to almost pre-diabetic levels just by giving them water that was sweetened with an artificial sweetener. And as soon as they change that back to a regular sweetener, sugared water, it goes away. Very counterintuitive, but there's always this talk about diet drinks can make you gain weight, and there's really some truth to that.
Well, then just get back to nature.
Water. Should you jump on the protein bandwagon?
If it involves bacon, yes.
Well, there's some evidence that says it's probably a good idea.
Okay.
But maybe more healthy proteins.
All right.
There's a lot of different diets out there, and so most of them are now promoting higher protein, less carbs. And as Americans, we eat more refined carbohydrates than any other country, and that really increases our risk for diabetes and heart disease and just a lot of bad things. And the obesity epidemic, you can blame on that. Over the last decade, even though we've pushed and everybody talks about protein, at the end of the day, we're only eating 1 or 2% more. And so we need to try to eat more lean protein, less carbs, but not no carb. I think that's where we draw the line. That gets dangerous. It causes a lot of metabolic things with the body.
Right. So the Atkins diet is, you would want Atkins light, I guess, right?
Yeah, and in fact, we'll talk about that. Big name diets work all for a while. That's our last headline.
That's right. Tell me more.
What happened? All these Atkins, South Beach, all these diets, what they do is they really just induce a healthier living, because most people start to exercise, they start to watch. So any type of diet that you start doing, whether it be who knows what name, there's tons of them out there, they ultimately you'll see a modest weight loss of about 5%. It's really about the healthy living and healthy lifestyle.
So does Wheat Belly come into this?
Yes, it
you
does.
were not a Wheat Belly
No.
fan a while back, but now he's a convert.
Convert's a big word.
Okay.
Speaking of weight loss, let's talk about some of the new weight loss drugs.
Yes.
Two new weight loss drugs,
It's
Belviq and Contrave.
Very excited about this. Tell us more.
Well, Belviq is one of the newer ones to the market, not the newest. This is a serotonin agonist. So it stimulates serotonin in the brain, or the receptors in the brain. And it stimulates, apparently, the receptors that they think are responsible for hunger craving. And so then when you eat in taking this medication, you're supposed to feel fuller faster and lose weight. And over about a year, we'll see about a 10% weight loss. So that's a 200-pound person. In 1 year of being on this medication, we would expect them to weigh about 180 pounds.
Yeah, and if you look at serotonin drugs in general, I think nausea and sometimes a loss of appetite is very common with these drugs. So that's sort of a unique feature of serotonin, brain chemistry, if you will.
The next one, Contrave, that's the newest one to the market. This one's a combination of bupropion or Wellbutrin, which some people know, and has been a weight loss drug for some time, used off-label, and naltrexone, which is something we use for someone who overdoses on an opioid and we want to reverse it quickly. And I think it's a really unique combination. It's not very well understood. They feel that the Wellbutrin or the bupropion tells the brain you're not quite as hungry. And the naltrexone, the thought, because they really don't understand it fully, is that it doesn't allow you to enjoy overeating. You know, they've been able to do MRI scans on people's brains when they binge eat, and they find that that same part of the brain that gets stimulated when you binge eat, that satiation, that good feeling, is the same thing certain drug addicts get when they abuse drugs like heroin and crystal meth. You know, and so they're using this style of medication to see if you can kind of cut the positive feedback loop to overeating. So you just don't enjoy it anymore.
They're fascinating, and I guess the only stone in my shoe is when they come to us and they say, well, we're not sure how it works. You know, you're taking a drug, may have central nervous system side effects, and you're ending up using the side effects of these drugs, nausea and loss of appetite, to get an effect. But it always makes me a little concerned when they say, well, we're not sure how it works.
Yeah, but it works.
It works. Kind of like marriage.
Very good. Okay, let's talk about something else we've seen increase incidence, you know, over the last couple of years, really the last 10 years, it's almost doubled in incidences. That's Clostridium difficile infections. Why don't we talk a little bit about what that is?
Yeah, C. diff is a big problem because we have patients who are elderly and they're immunocompromised to begin with. They come into the hospital, they get high-powered antibiotics for pneumonia, bladder infections, and the like. And we cure those, but then they end up getting horrible diarrhea, which is caused by this C. difficile, Clostridium difficile infection, caused by the antibiotic. And we have to treat it paradoxically with antibiotics given orally. But this stuff can linger around. It can be recurrent. It can cause a great deal of disease, dehydration, renal failure, perforated bowel. You can exit this world from a C. difficile infection. Maybe you want to elaborate a little bit more?
Well,
on
there's
that?
a couple of different, you know, one of the things this study really looked at is, you know, the outcomes, you know, how should we treat it? And there's a couple of different algorithms out there. But, you know, the Infectious Disease Society of America really came out with the best algorithm. And what this shows is if we stick to that algorithm and really use that correctly, we're going to see the least amount of morbidity and mortality. People still can die from C. diff, but we can lower the risk and problems associated with it if we stick to these algorithms. And so here's an example. You know, when we have a rather simple to mild infection, we use oral metronidazole. And that's the other thing is, you know, people think, well, it's an infection. Wouldn't an IV work better? And that's not necessarily true. We actually are treating the gut almost topically. For moderate infections, they want us to use things like vancomycin orally. For more severe, complicated infections, people are admitted to the ICU, have the megacolon, they're really, really sick. Then we use oral vancomycin and IV metronidazole.
There you go.
You know, that's kind of one of the changes that we've started doing in the last few months.
Yeah, there is a cookbook that we follow. And speaking of cookbooks following, I told you it was the fastest 30 minutes in television history. Thank you for joining us, allowing us to entertain and hopefully inform you. Remember, you're watching It's Your Health. We're your leader in healthcare information. See you next time.